So we're here today to talk about what more we know about COVID-19 and leukemia. As you probably expect, we're going to focus heavily on the vaccine program and changes and what more data we have. Surely that's what has really changed since the last time Helen very kindly came along and chatted to us about this topic. So if there are areas that we haven't covered when you ask questions later, we'll direct you back to previous webinars or give you some information on how to contact us at Leukemia Care later, and we can always talk you through anything we haven't managed to cover today. Just a reminder, if you wish to ask questions, you can ask questions if you're on Facebook in the chat, in the comments box underneath, and a colleague will get them to me. You can also ask questions through the chat function, or just introduce yourself, as many of you are now. It's always good to hear who we've got on the other end. So without further ado, I will hand over to Helen to do a presentation for us covering sort of what more we know since the last time we met, and then we'll dive straight into the many questions we've had in advance. Helen, over to you.
Hi everyone, let me just share my screen. Oh no, where's it gone? Not coming up, sorry, with the talk.
Is it the button or the slides?
No, it's the slide. I can't see the slides. I can see the screen share, but the slides aren't coming up on the. Oh no, sorry.
That's okay.
Having got it ready a minute ago. I might have to dial in again, I think. Sorry.
Oh, that's okay.
I'm not sure quite what's. It's come up. Don't know what's going on there. Oops. Right, can you see those slides?
We can, perfect.
Yeah,
Thank you.
Sorry about that. I don't quite know what's going on there. Yeah, so thanks very much for asking me to talk today. I've come really to give an update on, I think, where we are in terms of vaccine response data, and also where we're heading towards now in terms of managing the COVID-19 situation for patients with leukemia that are obviously immunocompromised. And I hope it's useful, and happy to obviously to answer questions at the end. I've predominantly focused on areas that I didn't cover in the previous webinar, so that in the interest of time we can cover as much as possible. So I won't go back over stuff I've previously presented. So just a few objectives. So I'm going to give a little bit of an overview on immunity, because I think it's quite important to sort of get an idea of what we're looking at when we talk about different vaccine responses, and then go more into where we're up to now in terms of recommended vaccine doses, third vaccine data that we have available to us to know how well these are going to work, and then also the latest on monoclonal antibody therapy. So just a little bit on immunity and also immunosuppression, and what we're on about when we talk about antibodies and cellular responses, first of all. So antibodies we measure from serum, which is in the blood, and we look at the different subtypes of what we call immunoglobulin molecules, and we can specifically pick off antibodies that we know recognize certain antigens. And in the context of COVID, there's much discussion about looking at spike antibodies, which I'll come on to explain shortly. So in case of antibodies, what they're important really for doing is hoping to prevent you catching and becoming infected with COVID-19. So we know that when antibody levels against this spike antibody are high, that helps to prevent us becoming infected with COVID-19. But there are reasons that people can't form antibodies, including people who have low levels of these serum immunoglobulins. So we term that hypogammaglobulinemia. And there are different subclasses of antibody that can be affected by that. And it might be that certain groups of those antibodies, such as IgA deficiency, may be more important for not being able to mount immune responses in this scenario. Talking about the other side of the immune system, we have our T cells, so our cellular immune system. And there's probably currently a lot less discussion around T cells, But they're very important once you have become infected with COVID-19, because they can recognize cells that are already infected with COVID-19. So on the one hand, we have our antibodies that are particularly good at what we call neutralizing or getting on top of the virus when it comes into contact with you. And then we have our T cells that are particularly good at identifying and destroying infected cells within our body. And we really need both sides of the immune system to be working to really prevent us from getting very symptomatic with infection. So the other reason, obviously, we get a lot of immunosuppression in people that have got leukemia is if they have ongoing therapy, and particularly chemoimmunotherapy, we know can make people very immunosuppressed and at risk of catching infections, and also a failure to mount immune responses to vaccines. And that also includes some novel agents too that are in our repertoire now for treating certain types of leukemia. So where we're up to, so COVID vaccination so far in leukemia has been exactly the same as it has been for the rest of the UK population. We've all been offered 2 doses so far of the same vaccine. This has been either the mRNA vaccines, which again encode spike, which sits on the envelope of the COVID-19 virus. And this is the Pfizer-BioNTech vaccine, or the Mrna vaccine. So those are the 2 mRNA type vaccines that have been MHRA approved and have been out in circulation now for many months. There's also the adenovirus platform that is the Oxford Astrazeneca vaccine. And this is again recognizing the spike. It's mimicked on the spike antigen that sits on the envelope of the COVID-19 virus, but it's a DNA molecule in this sense. Okay. So what do we know so far? So efficacy data in immunocompromised is still limited. We know that it's effective, the vaccines are effective in preventing infection from real world data in the population overall, but data I think is still lacking really for immunocompromised patients. We had data from Public Health England that looked at 1.2 million people in the at-risk clinical groups. And here they stated that vaccine efficacy against symptomatic disease was around 74%, which sounded great. But actually, when you sort of looked in further detail at that cohort of 1.2 million, there were actually only 139 that really came into what we call immunocompromised at-risk groups. So there are lots of reasons why people can be classed as being at risk of COVID-19, but in terms of the actual immunocompromised at-risk group, this was only 139 of those 1.2 million people. And the other thing is that data was really collected at a time when people were still shielding who were immunocompromised. So that obviously can impact the result there. And also when community transmission of the virus was actually decreasing, that was at the time when this data collection was taking place. So a few caveats there with that sort of vaccine efficacy of 74% that I think we need to sort of bear in mind when we consider our own risk going forward in an immunocompromised state. Data from the USA and Israel both suggest that around 40% of people who have been mRNA vaccinated that are subsequently in patients with COVID-19 are actually immunocompromised. So that probably gives us a little bit more of an idea of actually of the people who are ending up being in patients with COVID-19, the percentage of those patients is around 40% that have an underlying immunocompromised condition. So an update on immune responses since I last spoke. I think I'm going to come on to talk about the CLL data because obviously I've got that within our own study that we've been running in the UK. But I think the important study to probably point out here is the Greenberger et al. That came out very recently that looked at 1,445 hematology patients. And of those, they broke it down in the supplementary data to see exactly how many had each different type of hematological diagnosis. So I've picked out here just the leukemia diagnoses amongst that 1,445 patients, and to give you an idea of what the response rates were like following the second vaccine. So we have acute lymphoblastic leukemia, where they saw an 88% response rate to the second vaccine, but the number was small in that cohort. It was only actually 17. Acute myeloid leukemia had a lower response rate at 31%, and there were 34 patients in that cohort. And then amongst the chronic lymphocytic leukemia, we had a 64% response rate, which is really similar to what we've seen, and I'll show you shortly. And that was in a large number of 650 patients. Chronic myeloid leukemia, 100% response rate in 34 patients. And I think that goes with data that's been out there for quite a while now in smaller numbers, looking at the first vaccine response, where they also saw fairly comparable levels to healthy donor controls. Hairy cell leukemia, similarly, 100% response rate in the 7 participants that they looked at. So that's sort of to give you an overview of what is out there currently. I couldn't find anything else to update on the ALL or AML cohorts other than that study, really. And as I said, CLL I'll come on to talk about shortly. I would just say within that, there wasn't any data for ALL or AML in terms of who was on treatment or how far they were into their diagnoses, or whether they were all in a position where they had finished therapy either. So those kind of details are probably quite important, really, and probably impact a lot in terms of whether people were going to respond or not to second vaccine. And unfortunately, that data just wasn't there available in the letter that came out. So just a caveat there to bear in mind. So this is our own study that I'm sure probably many of you have been taking part in, and we're very grateful for that. So it's called the Cllvr Study, and we recruited 500 participants into the study. 484 were on an extended interval of where we obviously had the first and the second vaccine separated in time, so not on the standard 3-week apart, which is what the vaccines initially obviously were trialled at. And what the rest of the UK also ended up having because of the JCVI recommendation. So we found that 59% had actually had the Oxford Astrazeneca vaccine and 41% had had the Pfizer BioNTech vaccine. And we asked people to do a dry blood spot test if they lived remotely around the UK, or a 50 ml bleed. We actually went out to people's houses if they lived close to us in the West Midlands. And we asked for all sorts of data to go with it over the phone in terms of like infection history, to try and really build up a picture and to get an idea of how sort of clinical history really influences vaccine responses. So what we found, so we've analysed now in terms of the antibody data in the whole cohort. We've found that the percentage of vaccine responses is reduced in patients with CLL and is in keeping with the Greenberger and also data from Israel that's previously been released. And we found it's around 2/3 of patients were able to get an antibody response after 2 vaccines, compared to 100% in our healthy controls. The magnitude of the response, so the antibody titer that was achieved from the vaccines, was also reduced in patients with CLL, and this was around 70% lower. And you can see that on that bottom left-hand graph there. So on the right-hand side, you've got the CLL patients, and then on the left-hand side, you have the healthy donor as a comparison. And these were all people who had not been naturally infected with COVID-19. On the right-hand side, the graph, you can see on the left, the red dots. Those are the antibody responses of patients with CLL who had contracted COVID-19. And you can see that actually the natural infection really did seem to push up the antibody titer quite remarkably. So it was actually 32-fold higher than the vaccine responses. And this is all measuring the spike antibody response, I should just add. We then went on to see, lots of people have been asking about this, have we seen any difference between the Pfizer and the Oxford AstraZeneca vaccine? Well, no, we didn't. So large numbers, obviously, in this study, and we can quite confidently say we found no difference between the response rate. So 66% had response rate for both vaccines, and also no difference in terms of the antibody titer as well. So in terms of that magnitude of antibody titer and the response seen, there was no difference with either vaccine type. So the extended interval, I think this is something that we've been quite interested in, because we previously sort of published looking at the interval difference between the standard and extended interval in healthy donors in the UK. It was another study that we've been running. So we were interested to see whether in CLL there seemed to be any difference. And actually, yes, we did find that those who had had an extended interval did seem to have higher titers. There is a slight caveat to this in that those that got the standard interval, the majority of them were older by nature of the fact that obviously they had been invited into the vaccination program right back in December, mainly when the vaccine interval was still on the standard 3-week cohort, 3-week interval, sorry. But yes, we could see a sort of 3.5-fold higher increase in antibody titers. But obviously the downside of that is that extended interval did leave a longer period of vulnerability where patients had only had one vaccine. And we know that one vaccine really didn't get great responses in patients that had CLL. So on balance, it's difficult to say what in hindsight was the right thing to do, but I think now that we have gone through this and we've got this extended interval, we can perhaps be a bit more reassured that actually we may have ended up, I think, with higher titers because of it. So waning, so this is the first time I've shown this data, and it's quite nice. So it's up to 8 months after the second dose, and I'm showing here just participants that had had an antibody response after the second vaccine. So the middle column there is those that had a second an antibody response after the second vaccine. And you can see that actually the drop is about a third, but it's not statistically significant yet. So this was a median of 4 months after, but up to 8 months after that second dose of vaccine. And that waning is actually comparable with what we're seeing in healthy controls. So I think the good news of this is actually that patients with CLL don't seem to be reducing their antibody titers any quicker than the rest of the population. So that perhaps is reassuring as well. Yeah. Okay, and so the next thing we've gone on to do is look at correlates of protection. And for this, we've used live virus in the lab to actually see how well the serum that we've collected off patients that have been vaccinated can neutralize or get rid, if you like, of the virus in the lab. And what I should point out is obviously the vaccines were developed against the original Wuhan virus that was detected in Wuhan. But obviously since then we've got these new variants, of which Delta is now the dominant variant. So it has mutated, and the vaccines were not obviously designed specifically for the Delta virus. So Delta variant, sorry. So we were obviously anticipating that we wouldn't be able to neutralize quite as effectively against the Delta variant as we can the Wuhan, but that's purely because of the design of the vaccines themselves. So what we've found is actually there is a reduced ability to neutralize the Delta variant compared to the original Wuhan virus. And that is true in both healthy donors and CLL, which is what we anticipated. But it is slightly more pronounced in patients that have got CLL. So you can see if you look at the red dots here, the median line here is lower in the patient CLL group than it is in the healthy donors and here on the graph on the right. And I should just point out that this again is only tested here in donors that have a detectable antibody response after the second vaccine. So going on to what is now recommended, that's sort of where we're up to in terms of the data that we currently know on following 2 doses of vaccine. But what about looking forward to a third dose? Well, the JCVI have now recommended a third, what they call primary dose of vaccine for those that are immunosuppressed at the time that they received their 2 doses. So this is different to a booster vaccination that you may also have heard of, and I'll come on to talk about subsequently. So this third primary dose is to consolidate the primary course, and that is because we know that in certain groups of patients, we're not getting the full response that we would like to see after just 2 doses. So this third primary dose is to be given in close proximity to the first 2 doses. The government website gives really up-to-date information on eligibility, and I would encourage everybody to have a look at it if you are unsure if you should be getting this third dose as a primary dose that the JCVI recommend. It does specifically state that everybody who has acute or chronic leukemia undergoing treatment or within 12 months of achieving cure is classed in this category to have a third primary dose. There's also chronic lymphoproliferative disorders, which include CLL, so chronic lymphocytic leukemia, indolent lymphomas, myelomas, and other plasma disorders. They are also eligible to go along and have a third primary dose. Other stem cell transplant cohorts, there may be people who have had a stem cell transplant listening today, they also are eligible if it was less than 24 months ago, or if it's more than 24 months, but you have ongoing immunosuppression. So you may be on steroids, perhaps, if you've got some graft versus host disease. And then there is also a specific mention for those that are on targeted B-cell therapy. So that would include anti-CD20 antibodies such as rituximab or Bruton tyrosine kinase inhibitors. Also, there are caveats to this that I think if we look into it, there probably are reasons for other people who might not come up in the criteria above to also still be eligible for this third primary dose. And I would urge people to really look at that if they haven't already had their third primary dose. And if there is any concern or confusion, I would suggest discussing it with the GP and or your hematologist to clarify whether you should be getting that third primary dose or not. And obviously those that are having chemo, I should have said, would also, because of the nature of it being so immunosuppressive, be eligible. In terms of which vaccine, they state the mRNA vaccines, which is Pfizer or Moderna, but it can be the Astrazeneca vaccine if this was previously received and it facilitates delivery. So that's how they've suggested that we go forward with this third primary vaccine. And just to say that it is safe and it is okay to mix vaccines. You can have what they call heterologous vaccination, where you've had mRNA AstraZeneca vaccines before, and then you go on and have an mRNA vaccine. So third vaccine data so far, what do we know? Well, again, Greenberg has been busy and he's kindly got us some data on 49 patients that have got B-cell malignancies. And the breakdown of that is just there in brackets underneath. So we had 25 patients with CLL, 18 patients non-Hodgkin's lymphoma, and 7 Waldenstrom's. 48 of those 49 patients had all received an mRNA vaccine as a primary course. A third received the same vaccine again, and 2/3 received a different vaccine. When they looked at responses following the second dose, so this is as they're going into this study, 38 had no antibody response, 7 had a low antibody response, and 4 had levels of more than 100 units per mil, I should say. So 4 had slightly higher levels. Then after giving the booster, they looked at the same 49 donors again, and here they found that 35% of those non-responders initially after 2 vaccines remained non-responders. But you obviously have a good chance of getting a response even if you've been a non-responder after 2 vaccines. So this is encouraging. Then following the post-booster again, 65% were shown to increase their antibody titer, and 11 of those were previous responders, but 21 became positive for antibody responses. So 21 of those original 38 who had no antibody response after a third vaccine were able to show that they had an antibody response. So I think this is really encouraging, and I very much would suggest that everybody goes and gets a third vaccine, even if you know you have had no antibody response after 2 vaccines. Just to say, the only other data that's currently out there for third vaccine in an immunosuppressive setting is for solid organ transplant. And here again, they showed very similarly that those who already had an antibody response after 2 vaccine were able to increase their antibody titer nicely, so they boosted, whereas a good percentage who had no antibody response after 2 vaccines went on to seroconvert when they had a third vaccine. So what's going on in the UK looking at this? Well, there's a trial that some of you may have heard of, and I'm sure some of you are taking part in, called Octave Duo. This is recruiting 1,200 immunocompromised patients, including blood cancer patients, and we're now currently more than halfway into the recruitment. It's open in 4 centres, I think, so far, but there's a plan to extend into other centres very shortly. And the idea is that we look at no or low responders following 2 vaccines, and to see what the difference is in terms of the antibody responses and the seroconversion rate, so how many become antibody positive, And within this trial, it is a randomized trial where patients are randomized to either Moderna or Pfizer, which are the mRNA vaccines. And if you're in the lymphoid cohort, which is for the purposes of leukemia, the chronic lymphocytic leukemia cohort, there's also a Novavax arm. And so they're being randomized between these different vaccines, so we'll be able to see what impact the vaccines and the different type of vaccines make in terms of the antibody responses. And we're also looking importantly at the cellular immunity as well as the antibody immunity. And there is early reporting going on back to government to feed to feed back to them, so that any changes obviously that need to be made going forward can be made. So booster vaccination. This is different to getting your third vaccine as a primary course. So your booster vaccination happens at least 6 months after the last dose. Now, for people who are eligible for a third vaccine as part of their primary course, this will be a fourth vaccine 6 months later. So who is eligible? Anyone over 50, healthcare workers, or those younger but clinically at risk, which I imagine will be the majority of patients listening to this today. So Pfizer or Moderna are the vaccines that are recommended. Again, they're both mRNA vaccines. But again, they say Astrazeneca can be an option if you've had this for the first 2 doses. Currently, the government website states that it is expected that severely immunosuppressed individuals who will become eligible for a booster dose as part of a routine booster program from around 6 months after their third primary dose. But this is pending further advice. So we're anticipating that anybody who is eligible for a third dose now as part of their primary vaccine course will be contacted again 6 months down the line and asked to come in for a fourth vaccine. So I hope that will clear things up, because I know there has been quite a lot of confusion in terms of which vaccines actually people are eligible for currently. I'm happy to take questions on it afterwards as well. So moving on now to the role for monoclonal antibodies. So these are directed at that spike protein, again, that we talked about, that sits on the envelope of the COVID-19 virus. They're engineered monoclonal antibodies and they're designed to last months. There are 2 settings in which they can be used. They can be used as what we call prophylaxis, so where they're given as a preventative measure to prevent patients from catching COVID-19. And you can do this in the setting of people who have had known exposure to COVID-19, or it can be prophylaxis for patients and given just routinely if you know that patients are unable to mount a response to vaccination, or, for example, if they're going on to require inpatient chemotherapy and are going to be at risk. The other setting that they can be used is for therapy. So for when patients have been diagnosed with COVID-19, if they're known to be immunocompromised, that would be a setting in which monoclonals could be used. And we're going to go on now and talk about what evidence we have for using them in those kind of settings, and also where we are in the UK in terms of it being used. So first of all, I'm going to do with treating COVID-19. So this is in the context of people who have got COVID-19 disease. They have contracted the virus. So Ronapreve is a combination of monoclonals. So it's 2 different monoclonal antibodies which both target the spike protein on the surface of the virus. The first study looked at in excess of 4,000 patients, but in an outpatient setting. They had to be PCR positive, so they had to have shown that they definitely have the virus currently, and they had to have symptoms within 7 days of getting the drug. They also had to have 1 risk factor for severe disease, and then they could be enrolled. They received 1 subcut treatment, so subcut just under the skin, an injection of the Ronapreve. And this was found to reduce hospital admission. Remember, this was done in an outpatient setting, so this reduced the chances of them needing to go to hospital or death by 70%. It also meant that the symptoms resolved around 4 days quicker. So these are people that have got the virus, and we're able to show that it reduces the chance of them needing to go to hospital or death, and it reduces the time that they are symptomatic for. The second study, which was run in the UK as well, called the Recovery Study, looked at more than 9,000 patients, actually almost 10,000 patients, but this was in a hospitalized setting. So this study, again, you had to have confirmed COVID-19 PCR positive status, and you also had no immune response at this point. So when they looked, they found that those, they gave it, intravenous, not subcut, so slightly different, but the same drug. And here they found that the mortality reduced by 1/5 if you had no detectable immune response, so no antibody present to spike once at the point that you received the drug. For those that did have an immune response, so had a detectable antibody, and then went on to receive Ronapreve, they found no benefit to giving those people the monoclonal antibody. And you can see that quite nicely in the graph on the right here. So those that were seronegative here, this is their usual care. Oh, this is supposed to say mortality, sorry, it's cut off on the axis. Whereas here, you can see it's reduced when they get the drug. Whereas here, you can see the usual care compared to the monoclonal, the lines are very close and not much different in those that are seropositive and have a known antibody response to the spike protein. So that's very useful, because that kind of gives us an inkling as to where these drugs are really going to be useful and for which patients we need to really be giving and making them available for. And I'll go on to talk about that shortly. So within a prophylactic setting, so we've talked about when people have got COVID-19 confirmed, how we can use it to manage COVID-19 symptomatic disease. Now this is as a prophylaxis, so to prevent people from getting COVID-19. So again, Ronapreve, I'm going to present this data first. Again, there's a study that used it subcut, so underneath the skin as an injection. And this was in those who had no antibodies detectable to COVID-19, but were known to have been exposed to someone in their household. So they haven't got the virus, they've just been around somebody who is known to be positive for the virus. And here they found that those that were PCR negative and received Ronapreve within 96 hours showed a 66% relative risk reduction of going on to get COVID-19. Okay, so 2/3 reduction in chances of getting COVID-19 if they received Ronapreve within 96 hours. Those that also went on to become symptomatic and got COVID-19 were symptomatic with it, they found here that they had a quicker resolution of their symptoms, so 1.2 weeks versus 3.2 weeks, okay? And remember, this was in people who had no detectable spike antibody response before they had the infusion. And you can see there nicely that graph on the right hand, which shows the incidence of getting a symptomatic infection. You can see the blue lines, the placebo is much, much higher chance to become symptomatic infection than the red dashed line, which is those that receive the Ronapreve. So Ronapreve is now conditionally MHRA approved as a treatment and prevention for COVID-19 in the UK based on those studies that I've just talked about. I'm just going to go on and explain before I come back to Ronapreve and how we can use it in the UK, what other data there is for using monoclonal antibodies against spike as a prophylaxis. So we have the Provence study results that have come out since I last spoke, and this is the Astrazeneca monoclonal antibodies, again a combination of antibodies, and again this study used it in a prophylactic setting, so a preventative setting for people who were immunocompromised. There were more than 5,000 participants and they were randomized 2-to-1, so twice as many got the monoclonal antibody as placebo, and this involved 2 intramuscular injections separated in time. And here they found that the adverse events were very similar in both arms, so the drug was really well tolerated, which was good, but they found that if you received the intramuscular injection of the monoclonals, this reduced the risk again of symptomatic COVID-19 by 77% compared to placebo. And this is in the setting of prophylaxis, is not in people who were known to have been exposed. It was just they were given it as a long-term measure to prevent them catching COVID-19. They found no cases of severe COVID or COVID-related deaths in the treatment arm, so those that received the Astrazeneca monoclonal, but there were 3 severe cases with 2 deaths in the placebo arm. So again, I think this is good data. It shows us that these monoclonal antibodies are great at preventing infection and also treating infection in the slides that I've shown you before. So where we're up to with monoclonals in the UK, well, Ronapreve, as I mentioned, has got a provisional MHRA, well, conditional MHRA approval. The NHS supply has been secured, and you may have seen that in the press just over a week ago, and available supposedly in the UK from this week. I haven't actually come across anyone yet who's had it, but I'm sure there are people out there who have. And the question now is, how best do we use this resource? So it needs to be allocated to those who are most likely to benefit. And this is obviously, I think, the people that are immunosuppressed or are vulnerable and are unable to mount antibody responses. The Department of Health and Social have said that the initial supplies will be there for those who are unable to mount antibody response. So that mirrors what the recovery trial found. So people who don't have an antibody response should be able to get this drug if they become COVID-19 positive. So the government guidance currently is that it's for patients who become hospitalized, so you have to be in hospital to get it, with no detectable spike antibody response against COVID-19, and either aged 50 and over or 12 to 49 and immunocompromised. I think the questions we need now are that we do need a fast coordinated pathway in terms of delivering this antibody testing and awareness of this drug being available, and obviously early administration. We know that from that first study I mentioned that actually when it was given within 96 hours, we saw some benefit. So I think the earlier this drug is given in the course of the virus being contracted, the better. NICE guidance, I think, will probably follow, and there's a really nice review, a little article in the BMJ this week, if people are interested. It's open access, looking at Ronapreve and how, you know, it's going to be delivered in the UK and what thought processes need to go in, because we need to make sure that there is equitable access throughout the UK to patients who clearly should be receiving this drug if they become COVID-19 positive. So questions related to COVID-19, I think that still remain. I still don't think we've got a good grip on how antibody response relates to efficacy in patients that are immunocompromised. Is there a titer that provides protection against COVID-19? I don't think we know that yet. And equally, is there a level that sort of tells us, okay, we might get COVID-19, but will this protect us from getting severe COVID-19? And I think there we are really going to hopefully start to gain some more insight, probably by looking more at the cellular responses to these vaccines. And that's certainly where we're hoping to look next, I think. And we're already analysing it to try and understand how cellular responses really influence the immune response to COVID-19. And I think they're likely to be very important. Accessing monoclonals, I've touched on. I think we need to look and wonder whether, you know, this is going to be available to people outside the setting of hospital going forward. There is a finite supply of these drugs, so it's obviously going to be a case of where they are going to get the most benefit. And I think the decision so far to be used in hospitalized was the right one, but depending on how much resource that uses and you know, going forward, things it'll all be it's a continuing moving platform at the moment, isn't it? But I think that might be another area that may become apparent in the future as a further means by which people may be able to get hold of these monoclonal antibodies. And then finally, breakthrough infections and morbidity amongst the immunocompromised. I've yet to see really any convincing data on this, and I think, you know, that will be coming hopefully over the next couple of months. But I think the fact that it hasn't been perhaps out there readily already is probably an encouraging and good sign. Summary, I've just put so what I think are the key things at the moment, really. So a third vaccine is likely to benefit. So please, if you get if you think that if you haven't had your third vaccine and you think you're eligible by what those JCVI criteria were that I mentioned as the third primary course, please go and get your third vaccine. those with a positive response after their second vaccine are likely to increase their titer, and the percentage of those with a negative antibody response after the second vaccine are more likely to become positive. And remember, this is, again, just focusing on antibody data. Cellular responses may differ. So I'm trying to sort of say to patients, the immune response is not just about your antibodies. There's other elements to it that need to be factored in. It's just they're much more tricky to look at. And at the moment, that data is lagging behind because of that. But it will come. And then different COVID-19 vaccine to the first 2 doses is safe, because I get lots of questions about that. And there's been a large study in the UK looking at mixing vaccines, and they've said that it's safe to do so. And then improved vaccine responses following completion of therapy are now being reported. So I would just say to people who perhaps had therapy during their initial course of vaccination, that if you are somebody who's now finished your therapy, that would also be something probably to discuss with your haematologist and your GP about whether they would give you a further vaccine now that you have finished treatment and you haven't got that ongoing immunosuppression. Ronapreve, as I said, is available in the UK now for hospitalised patients testing positive for COVID without an antibody response. But I encourage everybody to get in touch with their haematology unit if you develop or you become exposed to COVID-19, because it is likely that, particularly in a hospitalised setting, these are the people who are going to probably end up coordinating and requesting the Ronapreve to be given. So I think it's helpful for us to be aware if you become COVID-19 positive. And then ongoing, I know I went on about it on my last talk, but remember to encourage household members and colleagues to be vaccinated. That will give you protection, and continue to be cautious. Masks, washing your hands, social distancing, just don't stop. We're not there yet where we can put our guards down. Yeah, I hope that's helpful.
Thank you, Helen, that you covered so much stuff. Look, plenty in there to be positive about as well, which is nice at this point in the pandemic. 18 months in, I didn't think we'd still be having these webinars. So yeah, I think that's really, really important to note the positive stuff. I thought, just looking at the questions, I think there is still some confusion about third dose versus booster. So I thought I would give a bit of a summary,
yeah, please do. Yeah,
and to make sure everyone's clear. So the aim of the third primary vaccine and the booster programs are different. So the third vaccine for the immunosuppressed is in people we suspect have had an insufficient response to the first 2, and we're trying to get them back up to where most people are. The booster is in people who have probably responded to keep them protected. Do you think that's a fair summary, Helen? I don't want to.
Yeah, I really do, yeah.
So if you are eligible for the third, you become eligible for that 8 weeks or more after your second. So that would be the majority of people right now, because the vaccine program started way back in December. So we're talking most people who are eligible for third should be having it right now. The booster, you become eligible for 6 months after your last primary dose, either your second or your third. So if you are having a third vaccine, hopefully in the future you will also get a fourth, a booster, but that is not 100% confirmed, but we suspect that will be the case. I think one really important thing I wanted to say that I picked up in your presentation, Helen, is don't wait to find out how you responded to the first 2 before you go for the third. I think based on what we know so far and the fact COVID is still here, that third vaccine is going to be beneficial regardless of how you responded to the first 2. Do you think that's also a fair comment?
Mm-hmm. Yeah, I think regardless, you'll benefit hopefully from having a third, whether you're a non-responder or a low responder. So it's irrelevant whether you find out. Yeah,
and antibody tests are still not available widely on the NHS. There has been an announcement the last couple of days that there is a study open for certain patients where you can find out your antibody levels for COVID, as well as participating in the research. So if you want to do that, there's more details on our website and coming out in an email in the next couple of hours. But not everyone will be eligible for that. Sorry, carry on.
I was just going to say, the other thing to remember is when you're getting a vaccine, you're not just stimulating your antibody response, you are also stimulating your T cells, so your cellular response as well. So although we're measuring antibodies all the time, there will also be ongoing tickling of your T cells, so boosting your cellular responses as well.
Absolutely. So yeah, the message is get whichever dose you're invited to. I will come on to problems in getting the doses a bit later in the questions, I think. The last thing I wanted to say is my understanding is that people who live with people who are immunocompromised, so the family members of many people listening, are eligible for a booster as well. So, but not the third vaccine. So hopefully they should be invited. Your household members should be invited for a vaccine 6 months after their second dose. That's my understanding of the JCVI recommendations for that, and I saw that question pop up.
Yeah.
Right. I hope that was useful for everyone. We've got many other questions coming up, so let's see what we can do to answer them. So we've got a question asking if the third vaccine will be the same as the first two I received. I think you covered that, Helen, but did you want to just quickly reiterate that one for us?
Yeah, so third vaccine is most likely to be a mRNA vaccine. So this will be Pfizer or Moderna in the UK. They have said you can have AstraZeneca if you had AstraZeneca as your first two, but this would be more because it will facilitate delivery. So it's easier, obviously, to store and give AstraZeneca. So they're saying if it means you get a third vaccine or you don't, then yes, go ahead and have AstraZeneca if you've already had two AstraZenecas. But I think they are anticipating that nearly everyone will end up with an mRNA vaccine as their third vaccine. And that goes the same for those that are not eligible for the third vaccine, but are getting a booster 6 months after their primary course.
Right, so you can have a different one. And it's possible it may be beneficial to have a different one.
Yeah. And that's the same for everyone. So everyone will be, who gets invited for a booster will be offered the mRNA vaccines as the first point of call.
Great. Before I come on to how you get the vaccines, a couple of other questions. A lot of people ask if there needs to be a difference in when they have their flu jab and a booster or a third vaccine.
No, so
I think that's no.
Yeah, it's not now. Last year we were very cautious. Obviously, there are very new vaccines that were around, and at that point, yes, you did have to have them separated in time. This year, they are saying that they can be given together at the same time.
Yeah, but I heard one doctor suggest one in one arm and one in the other, which is an interesting proposition. But for safety time, it's safety time. Someone's asked what we know about vaccine responses post-treatment or transplant. I assume they're talking about acute leukemia, which I believe there isn't a lot of data as you covered in your presentation, but did you have any more comments on that question at all, Helen?
Yeah, so we know that people who are post-transplant, so stem cell transplant, when their lymphocyte count's more than 1 or when they are more than 12 months out, they tend to have better antibody responses following the vaccines than those that are closer to treatment. And again, those that have had immunosuppressive therapy within 3 months, we know that if you wait those 3 months and then get vaccinated, the chances then that you will have a better immune response. Slightly different from the monoclonal antibodies, so anti-CD20, I think there, because that really directly inhibits the B cells, which are the cells that make antibodies. We're only starting to see antibody responses. Those 6 months would probably be the earliest where you would start to generate antibody responses after being on a drug such as rituximab, for example. We've sort of looked at this and found that people who are more than 12 months out from having anti-CD20 or rituximab seem to have much better antibody responses than those who've had it, the vaccines within the 12 months since they've had rituximab.
So there's you listed the anti-B cell therapies as one of the reasons to get a third dose. So if anybody isn't sure when they should be having it or whether they are a class of immunocompromised, please check with a healthcare professional, and they can assess you against the criteria listed by the JCVI. Okay, so we've had lots and lots of questions about GPs and their awareness of the third versus the booster, which I will try to cover now. So our understanding is that NHS England wrote to GP surgeries to make them aware that there is a difference between the booster and the third vaccine and who should have which. As with all these things, sometimes the communication doesn't work that way, and we are aware of several people coming forward and letting us know that their GPs don't know. So our advice at the moment is try to get your third. So contact us and we can share with you the link to that letter that went to GP surgeries, which might help remind someone at the surgery that you need a third vaccine, and we're more than happy to support you in that. But a lot of people then say, can I not just accept the booster? And NHS England advice is yes, and they will recode people at a later date. So I think it's just important that you try to get a vaccine as soon as possible, because at the moment, the booster and the third vaccine are the same vaccines that are being delivered. In the future, there may be a change where a half dose of Mrna is going to be used for a booster, but that isn't rolled out yet, and we don't know when that's going to be rolled out for certain. So as soon as that happens, we will flag that to you all. But at the moment, it's safe to book a booster if you have been invited for a booster. You may want to say that you're actually due a third, not a booster, and that may trigger some sort of recoding. There are multiple mechanisms by which you can receive a vaccine. I think the important thing is to try and get it sorted ASAP, and don't be afraid to say to the GP, no, this is the case, and this, and politely try and explain, because there has been some miscommunication. We're not sure how or why, and we are raising it with NHS England, but in the meantime, we'll do what we can to support you guys to get that vaccine. Helen, did you want to comment on any of that? It was sort of more policy related.
I mean, you're echoing also what I've come across as well, and it is very difficult. I think some surgeries seem to be more on board with what's going on than others, and I just think it's I think there are very clear website guidance on the government website, and if need be, print it off and take it along to your GP practice, because I think it's very clear there whether you should be getting it, and it definitely states that this is as a third primary dose, not a booster.
Yeah, and the timelines that you should have that third primary dose in are clear in that letter to GPs as well. So if they say, no, you have to wait 6 months, it's in the letter, it's 8 weeks or more. Yeah. So hopefully they should be able to get all the information they need.
Pretty much, if you're on that list, in terms of the timing, you'd be eligible, because everybody's near enough more than 8 weeks now since having their second vaccine. So
yeah, absolutely. So I hope that's really, really helpful for everyone. I appreciate it can be challenging as patients to challenge and to push back, but please continue to do so, and rest assured that groups like Leukaemia Care and other blood cancer charities are doing the same.
Just to add as well, I know that locally we are writing letters out to GPs from our haematology unit, so there may be other trusts that are doing the same thing, because I think we've realised that variant, and that's what we're talking about these days, because Delta is dominant, the Wuhan's not around anymore. So it's actually working out what level functionally prevents you from getting infection, and that data still isn't clear.
Great, thank you. And in terms of data in your study for CLL on people who are having particular types of treatment at the moment, we've already had someone who's gone from active monitoring to ibrutinib, but there's a few people asking if there's any more information on specific CLL treatments like Venetoclax. So without going into all the detail, are you able to sort of comment on that briefly?
Yeah, I'm just going to try and bring up the slide. So there is, and the paper should be out hopefully this week, early next week. So and obviously we will let Leukaemia Care know once it's out. We will I anticipate put it out as a preprint, so it should be fairly quick to be out, and in there is a figure which breaks the management of CLL down and looks at what vaccine responses are like, similar to what we found in the first paper. So those that are on watch and wait and untreated, and those that have had previous chemoimmunotherapy and are now in remission, they have the best responses. Those on Bruton tyrosine kinase inhibitors respond poorly, around, I think it was around 30%, I want to say. But what we can see is those that have been on BTKI and then subsequently have completed their therapy seem to have a much better response when they're vaccinated. And even if they go on to have a subsequent different line of therapy, the response rate does seem to be better than those who are currently on BTKI. But again, this is looking at antibodies. So I know I can see data coming through that actually where the antibody is lacking, there's still good cellular data. So what that means in terms of protection or against severe disease is again, it goes back to that correlate of protection that we still don't yet know, but the fact that we're all focusing on antibodies probably isn't incorporating the whole picture. In terms of Venetoclax, very similar to Bruton tyrosine kinase inhibitors we're seeing now. The numbers are smaller than we've got with the patients that are participants that are on Bruton tyrosine kinase inhibitor. So it doesn't come out when we've put all of the factors together to see what really predicts for being a poor prognostic factor, so an indicator of whether you're going to have a poor response. The low immunoglobulin levels and the Bruton tyrosine kinase inhibitor are along with actually being on prophylactic antibiotics, that's come through now. So if you're on prophylactic antibiotics because you've got a history of recurrent infection, that also seems to predict that you're going to have a poorer response. But actually Venetoclax hasn't come through in that analysis, but I suspect that is more to do with the fact that the numbers are not as great as they are for the BTKI, the Bruton tyrosine kinase inhibitor patients, because I can see the levels are still fairly similar to those that are on Bruton tyrosine kinase inhibitors.
Great, thank you. I can see there are still a few people confused about the difference between the third and the booster. So I'll try again, but remember you can go back and listen to everything we've said. You'll get a recording sent to you if you're on Zoom, or the Facebook Live will turn into a recorded video. But I'm going to make one last attempt, hopefully. I really hope this helps. I think the confusion is because of the terminology. But the reason why it's kind of important to know the difference is about the timings of when you can have each, so whether you can have it now or whether you have it later. So the third vaccine is for people who are considered immunocompromised according to the criteria that Helen presented earlier, and you become eligible for that 8 weeks or more after your second dose. So most people who are eligible for that are probably eligible for it now. The booster you can't have until 6 months or more past your second dose. So some of you will be eligible for that now, some of you won't be. If you are eligible for a third vaccine, this is why you need to push to get the vaccine now, because you need it within a sort of shorter time frame from the second to have the intended effect. But if you accidentally or intentionally book a booster instead, the message is don't panic about that. As long as you get a vaccine, it is fine. I hope that's helpful. I know it's really confusing, and if you still have any questions following this, we're more than happy to discuss it directly with patients. We'll put our email address up at the end. And again, if you're having any trouble explaining this to your GP, get in touch with us. We have documents that we can share to relay this information to your GP alongside you. So hopefully that's really helpful. But please don't wait to book it. Find out now if you are eligible or not. I think I believe we've covered most of the questions in relation to the efficacy of the vaccine. I'm just going to take one last check. There's been a few questions specifically about CML and whether they're considered immunocompromised or not, and therefore whether they should have the booster or not. My understanding is probably not immunocompromised according to those criteria, but I don't know whether you have a sense of that, Helen.
I think the data coming through suggests that actually responses are good in patients that have got CML, including those that are on tyrosine kinase inhibitors. I think the interpretation of the JCVI guidance in terms of acute and chronic myeloid leukemia that are on current treatment could be probably interpreted how you want on that one. They obviously haven't been very specific in terms of saying which of the chronic leukemias. But I would say from the data that's coming out that patients with chronic myeloid leukemia do seem to have much better antibody responses and titers than the other chronic leukemia, so chronic lymphocytic leukemia. So that's probably it, open to interpretation, I think, that one.
Great, thank you. If you're not sure, probably best to speak to your haematologist to find out.
Just to say, they need. When we talk about booster dose, though, absolutely you need one 6 months post. I was talking then about the third primary dose. Again, try not to confuse the situation more. Yeah,
so if you're invited for your booster, take it up and then find out if you were eligible for the third, because they can change the coding on your booster to say it was a third, and you then get a fourth later down the line.
6 months later.
Yes. I think I'm confusing myself now, so I think I'll leave that there. There was a question about watch and wait patients and whether they are eligible for third primary dose. If you haven't seen it in the chat, the answer is yes. They are covered by the comment about all CLL patients. I believe there's a criteria that specifically mentions CLL, and we've had confirmation that includes people on active monitoring.
Yeah.
So thank you for covering that for us. Okay, I believe I've covered every question that was related to boosters, third vaccines, and whether the vaccines work or not. But if anybody feels I haven't covered your question, please do flag as we move on. We've had a couple of questions about how people protect themselves from COVID, which we said we weren't going to cover in detail because much hasn't changed from last time.
No.
I think your point, Helen, about being cautious still is really important. I just wanted to remind people that if you're in Scotland and Wales, masks are still mandatory in certain locations, so that obviously does reduce the risk of visiting certain places. Is there anything you wanted to add on specific advice at all, Helen, or should we refer people to your previous webinar for more detail?
I mean, I don't think there's any difference in terms of the advice and guidance just be cautious and wear a mask and clean hands, try and social distance. I don't think anything's really changed. Yeah,
and I think your point about having your close contacts vaccinated, asking them to be vaccinated if you can. And as I said, if you live with someone, if you are immunocompromised and the people you live with also would like it, they should be eligible for a booster 6 months after their second vaccine as well, if they're not already eligible for other reasons. Okay, let's move on then to a couple of questions more related to your last section about the Ronapreve and the monoclonal antibodies. Someone's asked how you define no antibody response. So you mentioned that the Ronapreve is only available to people with no antibody response. Do you actually mean absolutely zero, or do you mean low?
No. So the absence of antibody response in terms of criteria that I'm aware of is the fact that you don't generate any antibody response. So it depends on which assay you have in your local hospital, and all the hospitals have got different assays. So on the Roche assay, anything below 0.8 units per mil is a negative antibody response. And as far as I'm aware, that would be, the criteria to get this drug.
Great, so it is low, it's zero or very, very low, which is
as far as I'm aware. I think, again, this is going to be something that we will be looking at as soon as we're put in the situation where we need to find out, but from what they say, it says no antibody response, which when you get a result back, it says positive or negative. So
okay, so that should be clear when you actually get the response as a patient in that situation. Great. And someone also asked this in relation, I guess, to response to vaccines more generally. Do we know yet what I think you hinted at this in your summary questions, things we don't know, but do we have any idea of what is a optimum response or a good enough response to a vaccine, to a COVID vaccine?
So I don't think we do have a specific, we definitely don't have a specific cutoff where we know, and we know that titers that we generate after first antibody, which were, I think our median was around 40 in our first study that we looked at, which was after first vaccine. Well, that correlated with about a 60 to 70% efficacy against needing to be hospitalized with infection. So we kind of have that, but we don't yet have a known antibody level where we can be confident to say, if you come across Delta, you're not going to get infected because you have this kind of antibody titer. And that also goes into, the functional data that I showed looking at neutralization, because the titer itself doesn't always, generally it does correlate, but it doesn't always mean that the antibody that's being made is as functionally good as you would like it to be either. So that's another factor in the equation as well.
Great, thank you. There was a very specific question about masks, but I'm guessing that's probably which mask is better. That's probably beyond what you're able to answer. Did you have any comment on masks at all? Are you aware of any research of the best masks to use?
I think Nick and I had this conversation when I saw him recently. I mean, you think by nature an FFP3 mask is probably going to be better than you know, a conventional thin mask, but at the end of the day, I think just wearing a mask, and if all the population was wearing a mask, we probably would, you know, hopefully be, well, we would be probably in a better situation, not just for COVID, but for other viruses. So we know last year that we didn't see very many of the other viruses that are problematic for lots of our patients as well. So, you know, social distancing and masks go a long way to infection control. And yeah, I mean, as you say, they're mandatory still in Wales and Scotland. So, and certainly inside buildings, I encourage everyone to wear a mask. Outside, you're probably, you know, in fresh air, you're less chance of viral droplet transmission, but certainly indoors, the risk goes up.
Yeah, absolutely. And I think that's why we've not covered advice, particularly in this webinar. Nothing much has changed in terms of how you can protect yourself. And if you want to sort of refresh yourself on the advice we gave in our last webinar, and we also have it in blogs on our website, so do get in touch if you want directing to other sources of information on that topic. I think we may have managed to cover most questions. There's someone who's I assume a CLL patient, asking if intravenous immunoglobulins are likely to now have COVID antibodies in it.
That's a really, really interesting question, and something that we are looking at. So they won't be there yet, I'm fairly sure. So we know on blood donations now, in the NHSBT, we're getting positive antibodies in the donor collections, obviously, and the storage time for plasma derived products is longer because we're able to store them in freezers, and I anticipate it won't be probably for another 6 months, I would have thought, before IVIG, maybe even longer, becomes COVID antibody positive. And then the other thing to factor in with that is what titer. So going back to titers again, how high in that pooled, you know, IVIG donation it would be for COVID-19, and whether that would actually be a protective level. These are all questions that are going to be coming up, I think, and really interesting questions that hopefully we'll get some answers to. Certainly amongst the study that we've been running, there are a good number of patients that are having immunoglobulin replacement therapy, and that is something going forward that we would really love to look into. And just to say that I am really grateful for everyone who's taken part in the study. Thank you so much. So, and then hopefully we're not pestering you too much, asking you to do more finger prick blood spot tests that we've been sending out in the post in the last couple of weeks.
I think everybody is very keen to participate in these sorts of things. Especially, I think people are more aware of the importance of clinical trials of lately. That's been one silver lining of COVID, if you like. Again, I think we have covered everyone's questions. Many of you asked very similar questions, so we did end up grouping them together, but I'm really sorry if that meant we didn't pick up on the nuance of your question, and we'd be more than happy to come back to them again. I'm just doing one more flick through everything. Someone's asked if the same applies in Scotland, Wales, and Northern Ireland as does in England. I'm not quite sure on what precisely in what that relates to, but in terms of the JCV advice being taken up, my understanding is yes. Mm-hmm. Everyone in every devolved nation will have access to both the third or the booster, depending on which one you're eligible for. Whichever one you're eligible for, you will get. I think the timelines of the rollout are slightly different. I think the third dose in England started being given out on the 13th of September. That may be different in Scotland, Wales, and Northern Ireland. I don't know the dates off my top of my head, but either way, the advice has been taken up, and if the vaccines are not being given out now, they will be very, very shortly. So I hope that's helpful. And if you need any more specifics, please do get in touch and we can try and find those dates for you.
Can I just quickly point out, somebody in the panel has asked about shingles vaccine and they can't have it because it's a live vaccine. This is probably also a good point to just mention that it's just been approved for patients who can't have the live vaccine. There is a recombinant shingles vaccine now that people who would normally be eligible for the shingles vaccine, you should be able to get through your GP practice. Okay, so you're not allowed the live vaccine, but there is a recombinant vaccine that is safe for you to have, and the government have just approved the use of that in the UK.
Yep, and we have updated our CLL, not our CLL, our vaccine pages, sorry, to reflect that news. So please do go have a look at that if you would like any more information on that topic. Well, that was quite a whirlwind and a lot of information. I feel like we've covered everything as far as I'm aware. Oh, someone's just pointed out, yes, when we're talking about the shingles vaccine, all shingles vaccines are only available to people between 70 and 79, regardless of whether you're immunocompromised or not. But if you are 70 to 79 and you're a leukemia patient, then there is now the opportunity to have the vaccine because there's an online version available. I hope that makes sense to everybody. Again, we've written this out in our general vaccine website pages. Thank you, Helen, for joining me to discuss that and all the data you presented. Yeah, I think we've got some really lovely comments about the talk. I agree, very, very informative. Again, if you need to look at it again, we'll have this available on Facebook immediately after we're done and on YouTube in the next couple of days, so you can sort of go back and peruse our advice at your leisure. Okay, just to finish off then, just a reminder of all the various information sources that we have available at Leukemia Care, our newsletters, our magazines, and we also do a podcast, and I've already mentioned the website for update on quite a few other topics we've mentioned today. If you need help with this particular COVID vaccine rollout, the best point of contact is our advocacy caseworker, and we can help you work out the logistics of which vaccine you should be having, and if you have any problem with the GP, please do get in touch. In terms of other support services, we've got a variety. Our helpline, our virtual support groups are still running, plus we're piloting a few in-person ones which you can find on the website. We also give welfare advice if you're struggling financially, and have a counselling fund as well if you are looking for more formal support. And just a heads up actually, which is good we're finished on the shingles point, because we are covering immunisations and CLL patients with compromised immune systems in our next webinar as well, probably covering flu, shingles and a variety of other things. So if you are a CLL patient, please do come along to that. It should be a really interesting discussion. Just a reminder of all our social media pages and our website at the top there. And finally, our email address and phone number for any further information. Thank you all for joining us today. Thank you again, Helen, for your time, and have a lovely evening. Bye, everybody.
Bye.